In this episode, I interview Lauren Erickson. Lauren is an occupational therapist working in rural Nebraska, treating a wide variety of clients. And over the past few years, she's become quite well versed in fascia science. Let's listen in as she explains how she applies these concepts to her daily practice. Welcome to the Fascia-Informed Therapist, the essential podcast for occupational therapy professionals looking to deepen their understanding of fascia's pivotal role in therapy and health. I'm your host, Amy Mayer, an experienced occupational therapist, practice owner, and dedicated educator. Here we'll dive into the fascinating world of fascia, exploring its significance in the human body and its critical influence on occupational therapy practice. Each episode will bring you cutting-edge insights, expert interviews, and practical strategies to help you confidently integrate the science of fascia into your therapeutic approach. Whether you're a seasoned practitioner or just starting out, our goal is to equip you with high-quality, evidence-based, and fascia-informed continuing education opportunities that will enhance your skills and benefit your clients. So join us as we unravel the complexities of fascia and transform the way you practice occupational therapy. All health and wellness practitioners are welcome. Let's learn, grow, and evolve together. Hi, I'm Amy, and this is another edition of the Fascia-Informed Therapist, and I'm really excited because I have two awesome people in the room with me. One, Caitlin Rambo's sitting in. We only have two mics, so we'll see if she gets it. And then Lauren Erickson is visiting. So, Lauren, please take whatever time you need to introduce yourself, whatever you would like everybody to know.
I've been an occupational therapist for almost 22 years. I did the first probably 15 to 16 years in rural healthcare. Kids were starting to get older, being in activities, and now both my kids will be in school. So I tried to take a job in the town that I live in to be more available for them. So I went from critical care, access hospital, inpatient, outpatient, home health, nursing home to now strictly outpatient. The clinic I work for, we do hands, primarily is what we're known for the occupational therapy world. But as we expand into other areas, that's kind of why I asked to come back to work for this company so that I could expand, kind of treating the whole individual. I still love my hand therapy, but trying to expand other areas. I'm a certified lymphedema therapist. I got that about 4 years ago. My daughter's 5, 5 years ago, and still really got to know the cancer and oncology population. So when I was at that critical care access hospital, I would treat every individual, whether it was a total knee, a total hip, a back, a breast cancer person, cervical cancer. I got to do a lot of occupational therapy with all those patients. So bringing it back strictly to an outpatient clinic where I'm at now is still treating the oncology, the pelvic floor, the lymphedema. I'm kind of doing it all in addition to what the OTs on staff still do.
Wow, I loved my time in rural care because you get to see that breadth of everything. Okay, so what initially drew you into an interest in fascia or myofascial techniques, or what first drew you into this genre?
I think initially years ago it was my own pain. I've had 7 orthopedic surgeries, have had chronic pain my entire life from what I can remember. With knee surgeries and Achilles tendon issues, like it was more for how can I be an OT and still practice the rest of my life if I'm in pain too? How can I take care of people if I can't take care of what is my main issues? Mm-hmm. So always had an interest in fascia science and myofascial release. However, it wasn't until I ran into you at we had our state conference a couple years ago. You were the sponsor and kind of was like, I'm an extrovert introvert. I don't like to talk to people in big settings unless I know what I'm talking about. I just happened to see your booth and saw all the textbooks and everything on there, and I was drawn towards the science that I knew that you knew. I was drawn to your table, and then I got to talking to you, and you just seemed very passionate about it. And then I got interested. I think you treated me as a patient, and I had such relief. And then brought a friend down for one of your professional classes, and really thought, as you know, in the lymphedema world, I was telling Caitlin earlier, lymphedema world, we always thought we can't stretch that because we could cause more damage to those lymph nodes. But another person in your class piped up, and she's like, I do it all the time. So knowing those stretches, knowing activities, self-care for those patients, those oncology patients that are having pain, having a lot of pain relief myself. I used to always have to wear shoes. Now I can barely stand to have shoes on. And I walk through the clinic barefoot quite a bit with socks on. But I'm a shoe convert. I go barefoot quite a bit. But it was more like seeing it in my own life. And I feel like that's sometimes when I'm teaching patients how to self-treat or do some of the stuff, I can speak from experience. Okay. Or you give patients just a little nugget and then they go with it and they're like, well, that felt so good and now I'm feeling it in this area. What can I do different in this aspect? Getting people to buy in with that self-treatment component. So I've taken a few other classes outside of what you have given, but a lot of that.
We'll talk about that a little bit. What courses have you taken, fascia-related, myofascia-related? Just list them.
I've taken the John Barnes myofascial 1 and 2 and fascial pelvis. Okay. And then for your classes, I took the 1-day CEU for professionals and then the myofascial 1 and 2 that you offer, the self-treatment ones. Okay. And then your online classes, I think posture was a phenomenal one. Yoga for your health. We live in an area where we have a lot of gyms and we get a lot of populations that want to know what they can do. And a lot of people are like, well, I don't want to lift weights. So the yoga class has been pretty amazing with teaching patients, well, there's different types of yoga and you have to adapt. I go to yoga at a ladies' gym and I still have to adapt my technique. Mm-hmm. And I think I took your functional after 50 class. Okay. Is that what it's called?
Something close to that. I think I actually renamed it the Fascia-Informed Woman.
Okay, maybe it's been.
Or no. Is that the Move Better?
I don't remember. But
I tend to rename things now and then. So.
That class teaching patients, you don't have to exercise per se. You can do these things throughout your day and incorporate throughout your day. And finding these little I call them fascia snacks. Or movement snacks throughout the day that they can do where they don't feel like they have to do a workout at the end of the day. They've done a lot of their non-linear exercise throughout the day and they feel better to do whatever they want to do when they get home.
Some of the exercise science is actually moving in that direction. More small snippets rather than big chunks of exercise. And yes, that is the Move Better, Age Better.
Okay, yes, that's
kind of how I live my life too. I put little snacks in all day long. Somebody asked me the other day how often I exercise, like how much do I do a week? I'm like, there's no way I can add that up really, because I don't do chunks except the classes I teach.
Yep. Even throughout my workday, like finding a minute here and there to do and teaching patients, well, when you go into a room, do this before you do whatever activity you went in that room to do. So they're doing that throughout the day, which is what I've incorporated into my work day.
I was stretching out there before, while you guys were finishing up. And I got my turn with you.
There you go. Okay.
Any other classes that you've taken?
The fascia science class.
Oh, okay. The big one.
The big one.
Just released this year.
Yes. And then I'm trying to finish up your self-treatment so that I can eventually hopefully teach.
Learning how to
teach my own.
Okay, yeah, that's something that we need to talk about before you leave.
All right.
So Laura wants to start teaching her own self-treatment, myofascial self-treatment classes in your area. And what else do you feel like you need after that class? Anything?
I'm not done with it yet.
Okay. But you've done...
I've been through it, yeah.
Tell me this. So you've self-treated yourself a lot. You've taught a lot of your clients already how to self-treat. Don't you think that you could put one together with all that you know?
I probably could. I think it's just nervous explaining to patients why they might be working on this area even they don't have restrictions. Like even working on coworkers where I'll work on coworkers that have pain, but I'll work on coworkers that don't. But just still trying to get them to see you still need to work on every part of your body, even if you treat the symptom eventually, or there first, but then eventually whole body treats.
Okay.
I don't know. I guess I haven't done the full. I've just done like, here's for your jaw, here's for your pelvis, here's for this. I haven't done the whole, teaching the whole body to putting it all together.
Here's what I just heard you say. This isn't, no, that's okay. She's making a lot of faces right now. What I heard you say, it's hard to get them to go something like this where they don't have restrictions. We need them to go other places to find other potential restrictions because we don't know if they have a restriction there because the fascial system is all one thing, right? And there might be a restriction in an unexpected place that's contributing to their experience of pain. Write that down, memorize that.
I'll write it down when I listen to the podcast.
It's in the class. It's in the class. So some examples we'll just do a little tangent here, and we'll make this a two-parter if we need to. So in the self-treatment class, people are always finding stuff they didn't know was there. Latent trigger points, you might call them in the traditional literature. But just in the last one that I taught, when Caitlin was working at the hospital, one of my friends came because she was having SI pain. And we did feet, and then we did calves, and she stood up and announced to the group that my back doesn't hurt anymore, my SI doesn't hurt anymore, because she found restrictions that were contributing to the pain. The problem isn't always where the pain is. And another kind of funny one is when we start the class, we go around the room and we ask people to just say what's bothering them on their bodies, and we try to find themes and then create the course around those themes. And one guy that was kind of drugged there by his girlfriend said, "Oh, my wrist hurts. I'm sure you guys don't have anything for that." And we just went through the whole body. We never touched his wrist. And then at the end, we go around again and we say, "How you feeling? What are you going to take home with you? Any questions?" And we got to that guy and he's like, "My wrist feels great." So, you kind of, once you do it a few times, you'll come up with examples like that you then can share your own stories with people or borrow mine.
I think it's softening the focus, because when a patient comes in with a script, we're insurance-based. We haven't transposed to the cash pay edition.
For sure.
So somebody comes in with a script, you treat the symptom, and I might get a carpal tunnel patient that the surgeon from upstairs has sent me, and we might do some other techniques, just trying to teach them something may have caused this. We have to find what caused it, but they may not know what else is causing that, I guess.
That's okay. That could be another huge rabbit hole. Is the insurance-based model and the mechanistic, microscopic view of if your wrist hurts, then we can't touch anything besides your wrist. And I don't know where it says that anywhere, right? Or is that a model that we're stuck in ourselves? If we explain in the documentation the science of fascia, do you think it would still get denied?
No, and I've actually branched out more with the patients, and I've talked to the surgeon upstairs that has referred some of these patients. I'll say they may have had this carpal tunnel surgery, but what caused it in the first place? Like you talked in a podcast about the lady that had perfect ergonomics all day, but it was the hobbies she did when she got home.
Oh, yeah.
So I'll pull in, what do you do? I'm an OT, I want to know all about you. What do you do when you get home? What do you do for exercise? What do you... how's your sleeping patterns? And I'll ask a lot of those questions. And I might give them the median nerve glides for that carpal tunnel, but then I'll add, okay, here's a couple other stretches I want you to do that may help that healing of that. Mm-hmm. And see if you get more fluid throughout your fascia, if that helps heal or have less symptoms elsewhere.
Yes, and I believe that since we're all interconnected via the fascia, that when we start to explore their history, their posture, how they move, what their habits are, like you just said, then that's going to make the connections that's going to allow us to treat in that area. Now, the example I would give would be my friend that came with the SI pain. When we were talking on the phone, the first thing I said to her, "All right, Tracy, what have I told you about your posture?" And she's like, "Oh, I push my hips forward and to the right." And I'm like, "Yes, you do that all the time." And and she said, "Well, I have to stand like that. I'm a badass." I'm like, "You can
shift to the other hip.
You can still be a badass and stand in other ways, right?" So if we can connect posture to when you're so far forward in your hips, what has to turn on the most? Your calves, your feet and your calves. So we have to at least explore that area in order to help her low back, her SI. So I think when we can make those connections with the science, hopefully the reader, if they do read our notes, right, mm-hmm. is going to say, "Oh, okay, well that makes sense." And until we really get the idea, the deeper science integrated in those connections with those other things into the hands of clinicians in a more typical practice, where it's just part of practice as opposed to something fringy.
Well, I use your posture assessment almost on all my patients, even though you said it. I will type in, like, from the front view, they scored this, and from the side view or the back, they scored this. And I'll explain to the patient, I'll have them stand the way they stand, and then after I get my assessment done, I'll give them a break, and then I'll have them come stand again without telling them any of the results. And then I'll put a mirror in front of them. And they don't even sometimes realize, oh, that shoulder's higher, and this hip's dropped, or my feet are outward. And being more in tune to my posture, I'm still working on it, posture and alignment per se, but we all are working at it. But I've even put that in my documentation, like the lower the score means there's more improvements for posture and alignment. And then I'll recommend for them other things, saying, I know we're treating that shoulder, but if you tuck that shoulder blade back and stand up taller and work on that, it's going to feel better. Mm-hmm. So I do your posture assessment with quite a few, and I document why I'm doing it with certain, especially my pelvic health patients. I mean, they're coming in for back pain or pelvic pain or other issues, incontinence. So I do a posture assessment on quite a few my cancer patients, pretty much everybody.
Okay.
I'll document on most patients, even if the script said pinky pain. The heck am I supposed to do?
Oh, Caitlin wants the mic.
One thing I was going to say is that, kind of with what both Lauren and Amy were saying, is that, a lot of times, though, the goals that we have in the traditional world, in the traditional outpatient world, the goal is not just, oh, I want this joint to get to this degrees, right? Because the goal from an OT standpoint is for whatever occupation they're doing. Every single occupation has a posture, right? Which is why we're looking at that from eval day. But also, every single occupation is multi-joint, and we can't have that microscopic view, because that's not OT, right? Mm-hmm. We look at the problems and we try to figure out what black and white can we fix. But as far as the definition of OT, right, everything is holistic and whole body, because the occupations are holistic and whole body. So for me, that's how, when I document stuff that I do in acute care ICU with fascia, that's my justification, because fascia's whole body and what I'm doing is whole body. And so that's my rhyme to the reason.
Whew, it's getting hot in here.
Oh boy. When I used to teach phys rehab assessments, I taught the only time you really want to go microscopic, as Caitlin described it, with your goniometer, is when your progress is so slow that that's all you got. But yet in the OT world, we spend 3 credit classes just on learning goniometry, and I don't know that that's really worthy of our time. But I have a different question for you, Lauren. Caitlin and I on social media had somebody, we'll say, bark at us saying that posture's not important. What say you?
I think it's extremely important. You can tell a lot by somebody when they're standing up versus if they're laying on a mat table. Things are different. Gravity's going to hold us in a certain way. I think it's encouraging patients and showing them, here's how you scored, but here's what we can kind of do with that. This is telling me what your body may need. They're more apt to try something that may not be directly related to what they came in for, that diagnosis that the doctor gave them, because they see, oh, I can see where I can make improvements, and just try a couple simple things throughout the day. I think posture, even for me, I find myself during the treatment day with a high-low table, trying not to be on a static mat table, taking my shoes off, doing my own fascial snacks with the ball underneath my foot while I'm treating people, doing my stretches throughout the day. I think it's huge.
How do you use the science, or how do you convince people that posture is important and connected to their experience of pain? Or am I putting you too much on the spot?
No. I think showing them how I ask patients, can I use your phone to take a picture of you before and after a session? So that's not on my phone or not on my computer, but taking before and after pictures. I've used if I get a shoulder patient, I'm like, okay, slouch, and now try to reach up for something. Can you do it? Now sit up straight, tuck your shoulder blades back, now try to reach. Showing them that you may have inflammation of that tendon, but here's maybe what caused it. The postural things you do throughout the day cause that inflammation. What is that inflammation telling you? Don't do it that way. Well, how can we correct it? Work on the more proximal, work on posture first. So pictures, showing them the assessment I give you before and after pictures is probably one of the better things to do.
Okay. Cool. Do you ever, we're going to drill down here. It's not a quiz. Do you ever talk about the fibroblasts with any of your patients?
A lot of my older forward neck head posture people.
Okay.
I'll talk about your body's trying to send more fibroblasts to that area to help, because your eyes always want to be upright. Well, if you've been on a computer down all day doing something and you go to look up, you can't. Your body has tried to correct that by applying more.
So they're
fibroblasts.
building you based
you.
on your choices
Yes.
for better, for worse, right?
And with cancer patients, a lot of like, well, if the fascia is tight, that can be a gateway for some of that to possibly spread.
Yes.
If you keep everything fluid and everything moving, it's a greater chance for the body to produce more collagen to help put that gate down and help stop that. Plus, you have less pain, less neuropathy, all those other issues that come with it. Exercise is really good medicine. So.
Yes. You've talked about posture as one of your go-tos for incorporating fascia science into your practice. Are there any other? You use myofascial technique. Yes.
Yes, I use myofascial technique.
And you
self-treatment. Teach patients how to kind of self-treat at home, or caregivers.
Why don't you tell me about some of the like stretches and exercises you give people?
Having people if I give them median nerve glides or whatever I gave specific to that, I'll have them do it in different postures.
Okay.
I'll have them do it sitting, standing, laying down in bed, so that they're doing it in different. It's not always sitting in a chair at 90 degrees.
Yes.
Right.
That's maybe what we're talking about, or
And
a kitchen sink stretch, or a deep squat while they're cooking. Something.
Oh yeah, that's okay.
Does fascia science make you look differently at nerve glide exercises?
It does, now that I know that fascia not only is our whole body system and contains all those systems, but it also goes around and through those areas.
And into the
So
nerves.
I talk about people, nerve glides are like flossing. I don't use that terminology anymore. I say your fascia surrounds it, and if the fascia is restricting that, even if you had surgery to release it, we're still doing with the scar tissue, but we still have to get that nerve moving in a different way. So I still give the nerve glides because that's what the doctors want. But I might say, well, let's try that in a different, let's try some weight bearing with that. Let's try some stretches with that. Let's try just some other exercises to hit that same
Okay.
nerve.
Do you use fascia science to help people move away from the no pain, no gain?
I do. I have taken away a few foam rollers in my time. I had somebody came in for tricep tendonitis, and he's like, I do all these exercises in the gym, and before I do it, I just go at it with the foam roller and try to get it all stretched out. And I'm like, well, let me try to do something different through this therapy session. So I just took him back to I call it my OT spa, very serene room. It's not out in the gym with the rest of the therapists. I bring him back, and I'm like, I want you just to do breathing for a minute. And then I show them the balls. And I'm like, it's not no pain, no gain. It's a therapeutic pain. Like, you can still breathe. You can still rest through it. You want that 2 to 3 to 4 minute hold on that. So trying to get people away from those lovely foam rollers.
Like golf balls
And golf balls. I mean, I keep a lot of those myofascial balls in our clinic, and we hand them out to people. They pay for them. I'll even give them a set and say, try this. And if you believe it, then you can buy it. And I better get them back, otherwise I'll just add $20 to your bill. But I have them try it at home with it too. Say, don't do the foam roller. I want you to try this before and after you work out, and don't hit it hard. And I give them a little sheet of paper that I think is in Jill Miller's book, The Body by Breath, that talks about go slow, breathe through it. It's not no pain, no gain. And in explaining to people, you can actually damage that fascia by doing this, but by doing it hard and fast. If you relax into it, you're going to change that dynamic throughout other areas by making that fascia more fluid in nature.
Okay.
Instead of just hammering at it.
Do you apply... Sorry, were you going to say something?
I said, does that answer that? Does that answer the question?
I wanted from you.
No, that's not what I meant. Did I go down a rabbit hole? No. Did that answer your question?
Rabbit holes are perfectly welcome around here. Do you apply that same thinking process or instructional process to traditional stretching? Like if someone's going to stretch their hamstrings or do the shoulder stretch or any.
I give them usually, so if I'm going to do a shoulder stretch and I want to get a certain particular area to be stretched, I might give them 3 different ways to do it. I don't want you to do the same stretch all the time. Hamstring stretches for my pelvic floor people, I have them do it 3 or 4 different ways. Bent over a chair, sitting down with the strap. I'll have them do several different ways and say, this might feel good one day, but this might feel better another, because we're changing the pattern that the fascia is laying down. So I don't give the same stretch to every patient. I might find what works for them and then tailor it more as they get more motion, less restriction, less pain, I guess. So
yeah, that's a very functional approach.
I feel like I get on MedBridge all the time and doing patient. I don't have a specific patient handout. Oh, you have carpal tunnel. You have pelvic pain. That's this. I feel like I do an individualized one for everybody that walks through my door, because everybody's different.
Well, and like you said with the fascia snacks too, right? You're trying to figure out what ways can you do this stretch, this hamstring stretch in 2-3 ways. But also here's, every time you go to your kitchen sink, or when you're sitting on the couch in the living room, right? Or when you're doing XYZ, right? How can I habit stack that into what you're already doing every single day? And then you're not having to spend, 2-3 hours at the end of your day trying to make up, I'm air quoting here, make up for lost time, because you're finding ways to tailor the stretches and the exercises and activities, not only just to the person, but also to their everyday habits, right? And that's kind of where those fascia snacks come into play.
That's where it becomes muscle memory, or the body actually craves it. I mean, I can know days I don't do any self-care. I wake up a couple times in the night with pain. Had I done stuff throughout the day, and even I'll block myself at work and be like, I'm just going to go to the bathroom, and I might disappear behind my door for 5 minutes and treat myself for a little bit before I can move on to the next person. But it becomes a habit, like you said, a habit, and then your body wants it and craves it, and you know what to do if you have that symptom or pain come back.
Yes, I would say the same thing with posture. I know if I've been out, slouching, my body wants to go back to good posture. It feels better. Tell me a story.
I've got so many.
Any cases where you've treated them differently or used more from the fascia perspective, maybe that you wouldn't have done before you started this fascia-informed journey of yours?
Well, I can say before my fascia-informed journey as an OT, I wouldn't have thought I could treat jaw pain. I would have said, let a physical therapist do it. But the company I'm working for now, one of the owners came up to me and he's like, can you fit my wife in sometime today? She can't close her mouth. I'm like, what the heck did she do? Like, what did you do to her when she was home last night? She can't close her mouth. Anyway, she came in and I just started asking her, like, tell me a little bit about the last things you've done the last couple months. Well, I just got done training for and completing a half marathon. Well, how was your breathing? Did you have a lot of pain? Asked her about like the half marathon training, some of the exercises she did for that half marathon. She's also a hospitalist PA, super, super busy, 12-hour shifts here, there, and a mom. So I was like, well, what do you do to self-treat? What do you do for some of this stuff? And so I said, well, treated her a little bit, looked about posture, but a lot of neck stretches, head stretches. She was really tight in that right upper quadrant from all that running that she'd done. She was a right-sided breather. So talking to her more about breathing with exercise, because she couldn't close her jaw, obviously, I treated her that day. And I said, I know you're a PA and I'm an OT, but I do intraoral work. Do you mind? Never would have thought before this fascia journey, I would say, can I stick my fingers in your mouth? But just 15, 20 minutes of intraoral work and then giving her some of the stretches to do and some of the ball work at home. By the end of the day, she was able to close her jaw. And she's like, I haven't done this for 2 days.
Isn't that amazing?
And I saw her a couple weeks ago and she's like, look, I can still close my jaw. And I'm like, good. She's like, I can tell where I'm tight now. And it wasn't just from here, it was coming from my chest and my breathing and my diaphragm. And when I get really busy at work and I'm not breathing, I can feel all that tighten down again.
Yes.
So never before as an OT, I know that sounds generalist, I didn't think I would be treating jaw pain.
And nor would you probably have looked anywhere beyond the jaw, right? Mm-hmm. Yeah. Yeah, in our TMD course, we teach to kind of move up toward it first when you're treating and as you're looking for tension. Any other cases that are interesting or?
I have a pelvic floor client. She has a very high stress job. Had seen physical therapy before for some of her symptoms, was coming to me more with general abdominal pain, constipation. So she's like, well, the PT did this and this and this with me, and that's what I want you to do. And I'm like, okay, well, I'll start there, but then I want to broaden my focus. As a lymphedema therapist, like working in that deeper abdominal, scooping, diaphragmatic breathing with pressure. Like I started to incorporate some of the fascial techniques for the psoas and some of the stuff on the front of the abdomen, thinking she just thought, oh, I'm tight, my back's tight, everything's tight, and that's why I can't go to the bathroom. Incorporating more breathing, Obviously, posture on the toilet was huge too. Cool. But incorporating, like teaching her how to release her abdomen if she felt really, really tight in order for her to have the ability to go more at home. I think that was huge because she was like, you're going to have me do what? Why do I need to work here when I can't go? So, I mean, introducing a lot of abdominal work to her. I mean, she has a huge copay every time she comes in, and my job was, okay, I want to see you for this many visits, and I want you to do a lot on your own. Well, now she's like, I'm doing that, but now I want to know how I can take care of this. So now she's bringing other areas, but it was the low back pain and the constipation that brought her to me originally. So that one was really neat to see her, you know, being able to go to the bathroom more often with less strain, less pain, better quality of life. She was already doing all the nutrition, everything she was supposed to do to help that, but something was restricted.
Interesting.
Restricting.
Okay, so how has your knowledge of fascia and fascia science, or has it sparked any innovation in your practice?
I think it's honestly changed a lot of what I think it's changed a lot of what I do with patients. I soften my focus and I know as OTs we try to see the entire person, but sometimes you get stuck on what they came in for. I feel like I've really softened my focus to the entire person. I watch them walk into the clinic. I get to know them throughout their journey. But I think before I would have just been like, here's some exercises and I'll see you in a week. Now I'll say, well, how did that go? What do we need to do different? Let's try adding this and habit stack that and see. So I think, a couple years ago, I wouldn't have done a posture assessment. I would have been like, okay, you're here for wrist pain, let's treat that. I feel like I'm starting to expand my view of the individual and really get to know them and what their body needs.
Have you ever just said, I wonder if this would work based on...
Oh, I wake up, my day's off. I mean, today's my day off and I'm already thinking of things I can do with people tomorrow, just talking to Caitlin. I can feel like my brain doesn't shut off now. I'm always thinking, if that were me, what could I do different? Could I add that? And sometimes I'll do something completely, treat a part of the body that I think where it's coming from, and it's not there, but they'll feel it somewhere else. And I'm like, okay, I'm going to treat there next. And so I think it's completely changed. I don't think I would be with the company that I'm in, doing the job that I am without having that knowledge base the last couple of years.
Do you think there's going to be more, as we learn more about fascia science and its application, do you think there's going to be more innovation available to us as occupational therapy practitioners?
I think so.
Yeah.
There better be.
There better be.
Better be. I think so. Yeah, I think we already are seeing lots of innovation in other disciplines. So I think we have tons of opportunity. Okay, how do you stay updated? Now you've taken all of my courses.
There's a couple there's a couple I'm not. I ran out of money. Stay up to date. I try to get on like Facebook blogs. People I try to keep in contact with people that have been to your courses or have taken other courses, and we do like visit on the phone or ask specific questions. That way, like a couple of the pelvic floor therapists I work with at my other company, we still talk about patients, and we incorporate fascia in that, even with some of the background that I've had versus what they've had. And we've all taken different classes. Like we'll say, well, have you tried this? Like I just asked Caitlin today, I had a former coworker say, how do I do something with the respiratory diaphragm if the patient, we do it on them, but how can they do it to themselves? So I told Caitlin, can I take a picture of you to show that therapist, try this? So incorporating some of those with other therapists, hosting let's just do a group chat about patients that we're struggling with, or what have you tried that you didn't think would be way out in left field that actually worked for your patient. So other therapists, talking to other therapists, listening to your podcast, of course, classes. I have a couple of fascia textbooks and self-treatment books that other people have written to see if that was other things I can incorporate in my practice. Mm-hmm. Unless I can give everybody your book for down the road. I do refer a lot of people to buy your book. I might show them a page and say, this is what I want you to do, but I really legally, I can't give you this because this person worked hard for it, but I'll give them the information to your website for them to order it.
Based on what you just said in terms of creating ways to communicate with other fascia-informed practitioners, did you happen to see your email yesterday from me?
I don't think so.
Okay, we are...
I was waiting.
We just are implementing, as of this week, a fascia-informed online community. anybody who's taken any of our courses, including the free course, it can admit themselves into an online community where you can connect with other people who are fascia-informed and want to problem solve about different diagnoses, different practice settings. And then we're also adding a membership where we'll have a once a month online meeting where we can problem solve together, talk about what's coming out. And so
Gotta check my email more.
well, there'll be more coming out in a more broad way, but we're super excited about it because I hope everybody has really seen how learning that it creates innovation, and I think it also creates excitement. Right? My words are expansion, innovation, and excitement, and I've heard you really talk about all three. You're being innovative with your clients. Your opportunities for treating them have expanded, right? And you feel excited about what you're doing, and it sent you into a new practice area that you didn't think you'd go into, which is super cool.
Well, and kind of like what you just said, right? This community that we've created, right, and is going to continue to grow, is going to do what you're doing on a little bit bigger of a level, right? And so, as much as we love the fact that you're doing that, because that is how you're staying up to date, and that's how you're learning yourself, and also learning from others, and vice versa for all those people you're in contact with. That's that interprofessional, intraprofessional collaboration, and so getting to do that on this level and getting to see, oh, this is how people in peds do this, or oh, this is how people in XYZ do this. That's what we're trying to create, and to have all of those factors. And it's just coming out now.
And what Caitlin and I were talking about the other day is we would love to see you join us at some point as a mentor in that community because of all the work you've done in kind of the more generalist setting, in a rural setting. You get to see so many different types of people, which is so cool. So.
And you're like number one fan, so like I'll tell that.
I was telling her, I'm like, you talk about going to Katie Bowman and meeting her, and you're like a girl fan. I'm like, I'm like that with you guys. Just because of how I see how passionate you guys are, and it's just amazing. And when you really love what you do, you want to learn more. Like we were talking about how many books that we have. I said my office is filled, and I like that people see my fascia, my anatomy trains posters. They see my lymphatic posters, but then they look over and they're like, well, I didn't know that you have one on back mechanics, but you're an OT. It's like, well, here's why I have that book. And I have like 20 copies of Move Your DNA.
Stuart yesterday.
Yeah.
My good buddy Stuart.
20 copies of Move Your DNA. I'm like, go read this, look at it. Like Katie Bowman is, I listen to her. She's amazing too.
Mm-hmm. Yeah, I think innovation happens when we start looking outside our own discipline, and when you're 20 years out of graduating, right? I'm 30-some. Caitlin, she's a year, but she spends time with us. So.
She's grandfathered in.
She's grandfathered in. So you start looking outside, and because you have such a solid foundation of OT-ness, that learning out there and then integrate, I wonder how this would work with that. I think that's what brings a lot of energy back into our profession, or our individual practice anyway. So my final question, what do you like best about being an occupational therapist?
Just being able to seeing a ton of diagnosis, a ton of different people, but being able to treat the entire person. I was telling Caitlin my caseload in the morning might be a wrist pain and a carpal tunnel and a tendon repair. By the afternoon, I have a double mastectomy, or I have somebody with a lobectomy that has pain, or I might see somebody with pelvic floor dysfunction that doesn't know what is causing it. So just seeing the whole gamut of diagnosis, people meeting a ton of people and having them say, well, what if my friend has this? Do you think you could see them? One of my patients owns a nail salon downtown, and she took a stack of business cards, and every once in a while she'll text me, she'll be doing somebody's nails. Hey, do you treat Achilles? Do you treat this? And if I feel like it's not something I have had a ton of experience with yet, I'll be like, no, but the person at my clinic that does it is this person. And I have a ton of support from all the therapists that I work with. I just did a breakfast with Lauren a couple weeks ago and did a fascia presentation with them, and showed them from Thomas Myers about what it looks like microscopically, when not just when you scrape it away as when you're doing anatomy, but what it looks like in real life. And I have PTs that are now catching me. Well, I have a patient with this. Do you think this will help? So just the community within my clinic, and just integrating myself more into the community that I live in, and just working with everybody. I think they're excited too that there's other things we can do with patients. Even the doctors upstairs have been like, well, I never thought about doing that. Go ahead and try it if you think you can get paid for it.
Are your docs like fascia?
Well, one of our surgeons is definitely on board. He's like, I have so many patients that I can't tell where their pain's coming from. If you can help them, I'll mark it on the script. I don't think we've had any kickback from any of the surgeons upstairs. If I even mentioned to this doctor, like, before you go to do a shoulder manipulation, can I just see him for a couple of visits to see if they even need that? So
nice.
I think the doctors, we're downstairs from obviously an orthopedic clinic upstairs, but no kickbacks there. Now we're just trying to go to the dentists in town and some of the family practices in town. I've only been at this job for 2 months, even though I've lived in the community for 16 years. So just reintegrating and saying, we can help that. Even though we have orthopedic in our clinic name, we want to be able to provide for anyone.
Yeah. Do you have any questions for us?
I'll think of something 10 minutes later.
Okay, well, you can text me. All right, well, Caitlin, thank you for being here. Lauren, thank you as always. Really, really appreciate you sticking around after your appointment today and letting us hear your perspective.
Thank you.
Thank you for tuning in to the Fascia-Informed Therapist. It's been a pleasure sharing insights and strategies to help you integrate fascia science into your practice. I'm Amy Mayer, and I hope today's episode has inspired you to explore further and take your therapeutic skills to the next level. Remember, we're committed to creating and providing top-notch, evidence-based, fascia-informed continuing education that empowers you as an occupational therapy practitioner. Stay connected with us for more enriching content, and don't forget to check out our online courses to deepen your expertise. Until next time, keep expanding your knowledge, refining your skills, and confidently applying the science of fascia to your practice. Here's to advancing together in health and wellness.